Okay, so like I said in our intro, and I asked you even, I confirmed before even we started recording, I was like, is this really, the only trial that's a randomized controlled trial comparing atherectomy to angioplasty alone? I mean, that's a lot. That's a lot to get into. I mean, before we even get into that, I mean, what is the current state of evidence, for atherectomy below the knee, and how did we get there?
There is evidence, but they're not randomized control trials, to your point. And what has happened is, while there is evidence, we use the word atherectomy, and it encompasses so many different types of things. Like, atherectomy is an action of, basically drilling or lasering or in some form removing the plaque in order to get through and through access and then being able to treat. But as I mentioned, it comes in many different forms. So even if we say, does, quote, atherectomy work? Honestly, since you have so many different ways of doing it, you really have to test out each one if you're really going to be scientific about it. And I think what has happened in this particular realm is, as we all know, you being in IR, obviously, and our cardiology colleagues, myself in vascular surgery, there's been a lot of drama associated with the word. In some circles, it's a bad word not because of atherectomy itself, and this is what the problem is, not because of atherectomy itself, but because of, frankly, what is being termed as overuse, right? I mean, we have a healthcare system that we all work in, and there are some people, not specialty specific, but some people that are a little bad actors that have been overusing all kinds of things, not just atherectomy, but atherectomy reimbursed decently. And so that's what got kind of the focus. And ultimately what that led to is a little bit of, group warfare, kind of gang violence between the groups that deal with PAD. So we say, atherectomy has more of a spotlight on it now, and we have to get the data, get the evidence, which is true. But if you look at other things, whatever, IVUS, drug-coated balloons, whatever you want to name off, all these other things that we use in the space, they aren't necessarily held to the same aggressive standard because they're not bad words. And so I'm not saying that overuse doesn't happen. Of course it happens. And I'm not saying that, the conversation around it shouldn't happen. But I think atherectomy has been unfairly targeted because, and we sort of are now using it interchangeably when what we actually mean is we want evidence about where it fits. I don't think anybody, when you have a conversation with them, says atherectomy has no place. That would be ridiculous. Nobody says that. What people want to know is, where is the space where atherectomy does help? And that's what this trial is all about, giving you that answer as a community, specifically for laser atherectomy.
Yeah. Okay. It's like the A word in PAD, I guess. The A, it's the A, the bad word.
Mm-hmm.
The A. Well, okay. So that's below the knee. I mean, what about atherectomy above the knee? Is there also, has a place been set up for atherectomy, whether it be laser or other, modalities of atherectomy for above the knee yet? Or again, is that also still a pretty big kind of blue ocean to figure out?
It's definitely still a blue ocean. There's really only one area that's for sure, FDA approved, everyone agrees, and that's in-stent stenosis. So in-stent stenosis, laser atherectomy, there's really no argument there. Everybody agrees. And it's interesting because in-stent stenosis is not going to be calcium, right? In-stent stenosis is that kind of gum that you stick underneath your table in school stuff, whatever that is.
Exactly.
And, and then we extrapolating from that, and there's no data here, this is just conversation. I'm thinking about my patients, kind of the young, 40, 50-year-old lady that comes in who has that weird, antiphospholipid stuff, that really soft plaque where the wire just flies and you're like, oh no, because that's just going to embolize.
Yeah.
I wonder if laser may have a role there because it's going to be similar-esque stuff, though to stuff obviously in the stents is neointimal hyperplasia, obviously, so it's a little bit different versus old clot. But I don't know. I mean, that's what we need to figure out before we move forward. But to answer your question, that is really the only place where it's for sure, get the laser.
Yeah, perfect. Yeah, that's true. I mean, the ISR laser. Do you use other forms of atherectomy for ISR, like Rotarex or things like that? Is laser your go-to in that situation?
For me, laser is the go-to. Other stuff can be used, especially there are some of the newer ones that say you can do it in a stent. Obviously, the concern is, especially a fresh stent, you gotta. I mean,
Yeah.
talk
Yeah,
about
okay.
like bad dreams, right? Oh my God, you don't want to blend inside the artery. There are, of course, they'll tell you like 30 days or sometimes 6 months if the stent has been in, then you can go ahead and do that. But specifically, laser is my go-to in that particular situation. And not just any laser, the recent ones, we all remember the days of the laser where like the contrast explosion, like no one wants to deal with that either, right?
Oh, yeah. Yeah.
But the current lasers, specifically the one that we're talking about, doesn't have that problem. I mean, when I talk to my residents, I tell them to think of like a bullfrog sitting on a lotus flower. Like how like it just has that like pouch that comes out and goes in.
Yeah. Yeah.
That's the same
I like
idea.
that.
So it's controlled. It's not this like
Yeah.
blast. So you can
This
shoot
blast.
contrast without having to worry about it anymore with this type.